So our next session is Yoshinori Ohsumi session. It is named after the scientist Yoshinori Ohsumi, who received the Nobel Prize in Physiology or Medicine in 2016 for his discoveries of mechanism for autophagy. Now I would like to introduce our chairpersons for this session, Dr. Kalpesh S. Kawar sir from Rajkot and Dr. Nimmi Mulwani from Ahmedabad. I would kindly request Dr. Kalpesh sir to please introduce our next presenter.
Very good evening to one and all. Our next speaker is Dr. P V Rao. He is working as a director and in Kumudini Devi Diabetes Research Center. He has co-developed the point of care devices for pre-eclampsia, diabetes, COVID, and rheumatoid arthritis in serum and glycosylated proteome in saliva. He has been executive member, secretary, president, and patron of the RSSDI in India. A well-known faculty, Dr. P V Rao. I would request sir to please begin this excellent session, please.
Thank you very much for giving me this opportunity to speak to you in SwasthyaCON today. I'm very grateful to Dr. Mayur Patel and his wife and his two sons who are also into diabetes now. Thank you very much. This topic is a very important topic for me because I am personally involved in doing these rapid tests for GAD and C peptide. Basically, the background is nowadays we are being told that there is a subtyping of type 1 and type 2 diabetes. From 1978, we have been following the classification of diabetes starting from WHO and AIIDR, and different organizations have been asking us to follow this particular classification of diabetes. But now, since 2016, there is a subtyping of presumed type 1 and type 2. That means they're almost saying that the type 1 and type 2 are presumptions. They are not real type 1 and type 2 as we have been thinking of. So I'll talk to you about the subtyping first. So 2016, some small populations in some small areas like Scania, Uppsala, this is all in Sweden. In small populations, both from diabetes registries and from people who are newly diagnosed with diabetes, they have collected their clinical characteristics plus biochemical characteristics like C peptide and GAD antibodies and try to classify them into 3, 4, 5 categories. Here you can see the names: severe autoimmune diabetes, severe insulin deficient diabetes, severe insulin resistant diabetes, and mild obesity related diabetes and mild age related diabetes. So when they have brought out this in 2016, I have not really given much importance to that, but gradually by 2017 and 2018 it has come in Lancet. Now people have been following this more rigidly, and all over the world people have been classifying their diabetes populations according to this and then publishing. So you can see here, this is American Diabetic Association this year 2020. So they actually accepted this particular classification, and they were trying to tell us that this particular classification has to be followed. Then I will show you the actual characteristics, the 6 main characteristics they have followed for classifying the clusters. So I just read out the clusters, the 5 clusters I told you. They are based on the 6 main clinical and biochemical characteristics like age at diagnosis, body mass index, GHB, then C peptide, HOMA-IR, and GAD antibodies. You can see here in this slide that they're not trying to differentiate between type 1 and type 2. This is basically supposed to be adult population. That means most of the younger subjects below 15 years of age have been excluded from this classification. But type 1 and type 2 are merged. LADA also merged with this particular classification. So both type 1 2, the earlier type 1 2 and earlier LADA, which we have been classifying, are now merged, and they are being told as they are being classified as severe autoimmune deficiency, SAID. So this is the classification. And then I will go to the next slide and see what is the clinical relevance of this particular classification. They have not shown any association with any major vascular diseases like coronary or cerebral in this particular way of looking at diabetes classification. But diabetic nephropathy seems to be more related to GAD antibodies. In Asian Indian population as well as in Asian population, here in this slide you can see the Japanese population. They have shown that GAD antibodies are actually considered as biomarkers for diabetic retinopathy in Asian Indian population and Asian populations. In other population, diabetic nephropathy. So small vessel disease has some relation with these GAD antibodies, and then that is the main reason for classifying them, but they have not shown much association with any of these large vessel diseases. We also done many antibodies, GAD antibodies, and 7 other antibodies. Before this particular classification, at that time we were looking at preclinical diabetes type 1 and type 2, and we have found out that GAD antibodies are also seen in type 2 diabetes. In this graphical representation, you can see type 2 diabetes is also associated with the presence of GAD, which is surprising. In those days, GAD is supposed to be seen only in type 1 diabetes. Almost like 66% of type 1 diabetics have GAD, whereas a few, maybe about 9 to 10% of type 2 diabetes and preclinical diabetes also have got GAD antibodies. Now, by the new definition of new classification, you can actually make a different way of looking at this presence of GAD antibodies. We have also done large population studies, but that time also we have taken preclinical diabetes and type 2 diabetes separately, and we have shown that GAD antibodies were also seen in preclinical and type 2 diabetes, almost like 10% of the general population with preclinical and type 2 diabetes have GAD antibodies. So there was an overlap and a merger, and the new classification seems to be giving more importance to this autoimmunity. We have developed the point of care devices for GAD antibodies, and they are also being used in the clinics nowadays. So you can see here, this is the center in Mayur Patel's clinic, and it is being used in the Mayur Patel's clinic. They use this small point of care device where you can find GAD antibodies in 10 minutes time. Then I will go to the next way of looking at diabetes. So Mohan also has brought out a classification of diabetes, a sort of a classification. It is from inspired study. So you can see here inspired study. So in inspired study, what he has taken population mainly from his own clinics, about 50 clinics in the country, about 20,000 population, and he has combined obesity, obesity and insulin resistance, combined obesity and insulin resistance from the previous ANDIS classification. ANDIS classification has separately shown obesity and insulin resistance, but here Mohan has combined them and he calls them as insulin resistant diabetes, insulin resistant obese diabetes, IROD. So two varieties, two combined, and they are being called as IROD. And mild age-related diabetes continues to be in the new classification as being given earlier also. Then severe insulin dependent diabetes, severe insulin deficient diabetes is something like our type 1 diabetes earlier. But now type 1 diabetes is not confined to younger population. Here, these are all adult population. So severe insulin deficient diabetes or something like type 1 diabetes is also seen in the elderly population. Then Mohan brought out a new entity called combined insulin resistance and deficiency. That is called CIRDD. So combined insulin resistant and deficient. So he says that this particular variety is seems to be more often seen in our general population. Earlier, we had different categories like insulin resistance and ketosis resistant, that is ketosis resistant diabetes in young, where you also have a lot of insulin resistance. So similarly, you have two contradictory characteristics by biochemistry being seen together in a single entity, and that is called combined insulin resistant deficient diabetes. This is what Mohan has described, and then we will see what is the clinical relevance of that. Before that, I'll show you one case report. This lady is a 52-year-old female, and she is diabetic for about 6 years. After 6 years, her blood sugar seemed to be very high, and recent hemoglobin A1C is about 13% in November. 13% in November. But sometimes her blood sugars fall as low as 51 and 74. As you can see here, it is only 51 and 74, 51 fasting and postprandial of 74. Sometimes it is into hypoglycemia, sometimes it is into hyperglycemia. But overall, glycated hemoglobin seems to be very high. And this patient was subjected to C-peptide and GAD antibodies, not by point of care devices, but from the lab. C-peptide, both in fasting and postprandial, seems to be 0.05. This is a typical insulin deficient condition. Then GAD antibodies are also very grossly high. These are about 5 times more than what is normal. So the patient has both GAD antibodies and also grossly deficient C-peptide value. So we classified this lady as LADA because it's a 52-year lady with insulin dependence. We classified as LADA, but now with the current classification of Mohan, which is published last month, so we have to take this particular type of subject as combined insulin deficient and insulin resistant diabetes. So in his data, the clinical relevance of this particular condition is that CARDD, that is combined insulin resistant insulin deficient diabetes, they seem to be difficult to be managed. That's the idea. Because you can see here these 4 lines here in the graph. You can see severe insulin deficient diabetes. Yes, we understand that their control of diabetes is poor. You can see here in the lower line, and then you can see the upper line, that is a mild age related diabetes. Control of diabetes is good in them. So in between we have insulin resistant diabetes and this particular combined insulin resistant as well as insulin deficient. So it is very difficult to control them. So that's what he has written, and probably they are also associated with the microvascular outcomes. So that is what his paper, which is called Inspired Study, published in BMJ 2020 August. So there are now subtyping of type 1 and type 2 type. The whole adult population has been subtyped into 5 categories by Andis and 4 categories by Mohan. So probably in near future we are going to see more and more of these subtypings. If you look at the actual occurrences or the frequencies of these particular types, you can see here the SAID, that is severe autoimmune diabetes by Andis classification, seems to be about 6%, and probably something similar to that by Mohan's classification is this combined insulin resistant and deficient, which is about 12%. Then if you look at the obesity and resistance, insulin resistance and obesity are combined and called as IROD by Mohan's classification, constitute about 26% of the population, whereas it's about something similar to about 37%. Yes, here you can see insulin resistance is 15%, and obesity, mild obesity related, is 22%. So 37% of the population in this Sweden seems to be resistant and obese, and here in India it's about 26%. So these are the two ways of looking at diabetes in near future, mostly in adult population. So, and both of them depend on GAD and C-peptide. GAD and C-peptide. GAD for insulin resistance and C-peptide for insulin deficiency. So you can also try to differentiate between the LADA and the type 1. Earlier we were doing like that. We are trying to differentiate between LADA and type 1 diabetes by doing their C peptides. But nowadays, you see, with this new classification, just do a C peptide level, and then uh, you can uh, you can say that they belong to SI, severe insulin autoimmune disease, insulin deficient disease, or combined insulin deficiency resistant disease. So C peptide seems to be an important biochemical parameter in differentiating adult diabetic population either by Andis or by Mohan's classification. This particular point of care device for measuring C peptide quantitatively takes about 15 minutes, and we have extensively looked at the different populations of preclinical diabetes, type 2 diabetes, and type 1 diabetes for C peptide, and we try to make a nomogram and then try to look at the normal and abnormal values, and we consider a non-fasting C-peptide value of 1.5, 1.5 nanogram per ml. Non-fasting C-peptide of 1.5 nanogram per ml is a cutoff point between normal and abnormal. We also tried finger prick tests like our blood glucose. If you look at C-peptide for a finger prick, it is possible to show a good association between finger prick C-peptide and serum C-peptide or the whole blood C-peptide. This is the graph that shows that there is a good association. It is also possible to do C-peptide either from finger prick, from a capillary blood, or from venous whole blood, or from serum. So this graph shows that particular value, and this is also approved by CDSKO, and it is also available in the market now. So ultimately, the conclusion is now C-peptide and GAD antibodies seem to be the two real biochemical parameters required for classifying adult population with diabetes. In near future, people are going to use more and more of these two biochemical tests for describing the clinical features of adult population based on their clinical characteristics as well as from biochemical. In Hyderabad, we have this facility to make point of care devices for some of the uh, diabetes problems as well as for preeclampsia. So, and everything is made in India. We are proud about making point of care devices for diabetes and some of the related conditions. Thank you very much.
Thank you so much, Dr. P V Rao.